All right, let's get started with a really high-yield review of the 2025 AUA/CUA/SUFU guideline on recurrent, uncomplicated UTIs in women. If you're gearing up for certification or just want a solid refresher, this is information you absolutely need to know. Let's dive right in.
Okay, so here's how we're going to tackle this. I've broken it down into a 5-module syllabus to make sure we cover everything logically. We'll start with the foundations of recurrent UTIs, then walk through the clinical diagnosis. After that, we'll talk about assessing patient risk, which is crucial. Then we'll get into the meat of it with guideline-directed treatment, and we'll wrap it all up with monitoring and follow-up.
So, let's kick things off with Module 1, the foundations. We're starting with the absolute basics here, but they're critical. We'll lock down the precise definition of a rUTI, look at who it affects, and then get into the pathophysiology. You really have to understand the what and the how before we can even think about what to do about it.
Yeah, this is a definition you'll want to have memorized. The guideline is very specific. rUTI is 2 separate infections in 6 months or 3 infections in 1 year. But here's the kicker, and it's a key detail for any exam question. There has to be a complete resolution of symptoms between the episodes. If the symptoms never really go away, we're talking about something else.
So why is this guideline such a big deal? Well, just look at this number. 60%. That's not a small figure. We're talking about a majority of women experiencing a symptomatic UTI at some point. It's one of the most common things we see, which is why getting this right is so important.
And for a huge chunk of those women, that first infection is just the beginning. The data shows that anywhere from a quarter to half of women who have one UTI will end up having more. And that's the exact group of patients this entire guideline is built around.
Okay, now this slide is where things get really interesting. This is probably the biggest conceptual shift in the entire 2025 guideline. We are officially moving away from the old school idea that urine is sterile. That's out. The new model, the human as habitat model, recognizes that the bladder has its own native microbiome. This changes everything. Our goal is no longer to sterilize the urine. Instead, our goal is to make the patient feel better. Symptom relief is the new target.
All right, so with that new paradigm in mind, let's move into Module 2. How do we actually diagnose this? We're going to walk through the entire diagnostic workflow, from the moment the patient comes in the door to interpreting the evidence.
So when a patient presents with symptoms, the guideline gives us a really clear 4-step playbook. Step 1, you start with the basics, a complete history and a pelvic exam. That's just good medicine. Step 2 is a urinalysis with microscopy. Step 3, and this is a moderate recommendation, is to get a urine culture with sensitivities. And finally, Step 4, another core principle, is to make sure you're not dealing with a contaminated sample. It's a logical progression. Okay, pay close attention here. This is a classic board question. The colony count that screams infection is totally different depending on whether the patient has symptoms. For an asymptomatic woman, you need that classic high count, 10 to the 5th or more, mostly to avoid chasing contaminants. But for a woman who feels miserable and has classic UTI symptoms, the bar is way, way lower. A count as low as 10 to the 2nd can absolutely be significant. Context is everything.
So what are the usual suspects we see on that culture report? Well, no surprise, E. coli is the undisputed king here, causing the vast majority of cases. But you also have to be on the lookout for other players like Proteus, Klebsiella, and Staphylococcus saprophyticus. These are the bugs you need to have on your radar for uncomplicated cystitis.
So with all this cool new tech out there, you might be wondering, why are we still messing around with old-school cultures? Shouldn't we be using things like next-generation sequencing or PCR to get a better answer? It's a great question. The guideline's answer to that is a very loud and clear no. And I love this quote. It really sums up the whole philosophy here. The answer to improved antimicrobial stewardship lies not in better testing, but in better clinical judgment. These new tests are so sensitive they often just create confusion. Our clinical skills are still the most important tool we have.
Okay, Module 3. This is all about knowing your patient. Because here's the thing. Before we jump to treatment, we have to understand exactly who we're treating and what we can expect to happen with them. This is all about risk and prognosis.
This is so important, I can't stress this enough. This guideline is not for everyone. It's laser-focused on one specific type of patient, what they call the index patient. This is a healthy woman with recurrent bladder infections and no other weird stuff going on.
On the other hand, if your patient has complicating factors like a neurogenic bladder, a catheter, is pregnant, or is immunosuppressed, this guideline does not apply. You have to know who's in and who's out.
And here's the good news for that index patient. Their prognosis is actually really good. The key takeaway is that for these women, the infection tends to stay put in the bladder. It's very, very rare for it to travel up and cause a kidney infection or pyelonephritis. This is a huge point for patient counseling to help manage anxiety.
All right, let's get into the meat of it. Module 4, what do we actually do about these infections? We're going to cover both the antibiotic options and, just as importantly, the non-antibiotic strategies that are becoming a bigger and bigger part of management.
Okay, first-line antibiotics. The guideline gives us 3 strong options: nitrofurantoin, trimethoprim sulfamethoxazole, and fosfomycin. Notice the duration. We're talking short courses, 7 days or less. And here's a clinical pearl for TMP-SMX that you have to know for your boards. You should only use it if your local resistance rates for E. coli are under 20%.
But what's really great about this guideline is how much it emphasizes getting away from just throwing antibiotics at the problem. We've got a whole toolbox of non-antibiotic strategies for prevention. Things like cranberry products, which get a moderate recommendation, methenamine, which can be offered, even something as simple as drinking more water if the patient isn't getting enough. And then there's vaginal estrogen, which is a game changer for a specific group.
Speaking of those non-antibiotic strategies, there's one population that gets a special shout-out, and you can bet this will show up on your exam. Let's focus on perimenopausal and postmenopausal women.
You need to have this statement down cold. Guideline Statement 20. For perimenopausal and postmenopausal women with recurrent UTIs, clinicians should be recommending vaginal estrogen therapy to cut down the risk of future infections. This isn't just a maybe, it's a moderate recommendation with grade B evidence. It works.
Okay, we're on our final module, monitoring and follow-up. This is all about what happens after you've treated an acute infection, and it brings us right back to that huge paradigm shift we talked about at the very beginning. So here's a question we get all the time. Should you do a test of cure culture after treatment? The guideline makes this super simple. If the patient feels better and has no symptoms, the answer is a clear no. Don't go looking for bacteria. But if they're still symptomatic after treatment, then yes, absolutely get another culture to figure out what's going on and guide your next move.
And this brings us to what might be the single most important practice-changing statement in the entire document, Guideline Statement 8. It's a strong recommendation, and it is simple. Do not treat asymptomatic bacteriuria, period. It doesn't help the patient, and in fact, it causes harm by promoting side effects and driving antibiotic resistance.
So when you put it all together, what's the big picture here? This guideline is really asking us to fundamentally change our thinking. The question we need to ask ourselves isn't, are there bacteria in the urine? The question is, how does my patient feel? In this age of antimicrobial resistance, that shift is more important than ever. Our focus has to be on treating the patient, not the lab slip.